Good morning and welcome to this lecture on musculoskeletal imaging. My name is Dr. Nicolene Lottering and I am one of the anatomists that you will see within years 1 to 3 of the medical program. Specifically, I will be responsible for the teaching within the musculoskeletal anatomy block in MEDI12-201. And today we're going to kick off with plain film radiographs. So the assumed knowledge for this specific session is that you've watched and are familiar with the Introduction to Imaging Modalities session in MEDI11-102, and then also that you have a very well-rounded or well-versed knowledge of the osteology of the appendicular skeleton. So that is the bones and the bony parts of our long bones and all of the bones that encompass our extremities, being the upper limb, lower limb, as well as our vertebral column and our pelvis. I would like to acknowledge the Kumbameri people of the Yugambeh language group, who are the traditional custodians of the land on which Bond University stands. We would also like to pay respect to the Kumbameri elders, past and present, and extend this respect to the Aboriginal and Torres Strait Islander people who are joining us from other communities today. Let's kick off with the learning objectives for this session. Firstly, by the end of the session, you should be able to describe and apply a systematic approach to viewing and interpreting radiographs of the appendicular skeleton. So specifically, in the second part of this video, we will cover a 5-step approach to viewing and interpreting X-rays. Secondly, you should be able to recognize and identify the normal bone, joint, soft tissue anatomy of the major joints of the appendicular skeleton in an attempt to accurately describe abnormalities that you might see when presented with plain film radiographs in this case. And thirdly, you should be able to apply appropriate radiographic appearance terminology as well as anatomical terminology to the interpretation, viewing, and description of common injuries, whether it be fractures or dislocations, as seen on musculoskeletal imaging. If you need to brush up on some of this assumed knowledge when it comes to radiographic appearance, please refer or watch the following Lightboard video that steps you through the radiographic appearance 3-point criteria for radiographs and CT scans. So we need to think about, why would you request medical imaging, specifically when we're assessing the musculoskeletal system? I'd like you to remember that medical imaging is always one part of the puzzle when it comes to the overall clinical picture. So as you've learned in clinical practice, your history taking and your physical examination is always core. The anatomy is important for you to understand the scientific basis behind both of those things, but then medical imaging forms part of the puzzle of investigations to help you to answer your clinical question. So it is always important to remember that medical imaging referrals should be used sparingly and should only be done when necessary. You would also remember from year 1 that we have spoken about the pros and cons associated with each of the imaging modalities, and therefore we always need to also weigh up the risks to the patient. In the specific session, we're talking predominantly about plain film radiographs or X-rays, and you will recall that this is a type of radiation-based investigation, meaning that the patient is going to be exposed to radiation. One-off, it's not such a big deal, but obviously the cumulative effects in terms of being constantly exposed to radiation can have some significant consequences. So let's think about, why would you request a scan? There are 3 main reasons. So firstly, to either detect or confirm a diagnosis based on your clinical question and your other array of investigations. Secondly, to exclude a diagnosis. And then thirdly, to stage a known diagnosis. So this could be through the diagnosis of complications or looking at monitoring progressive treatments, for instance. So as I've mentioned, the role of the clinician is to request the best test or investigation, to provide adequate clinical notes for the imaging, and reporting to be optimal. You should also be able to understand and act upon the result. So therefore, having a well-rounded knowledge and familiarity with radiographic appearance and some of the language that we use to describe common injuries, common trauma, or other pathologies that you might see is going to be really important for you to actually be able to understand the radiology report, but also to verify or validate if required. If we focus on the imaging of bones, which is the premise of this particular session, our gold standard is always going to be X-rays or plain film radiographs. This modality is probably the most conservative in terms of the first line of referral, but it's also going to be good enough given the purposes of our investigation. So with X-ray, we can clearly see the anatomical structures, the different parts of the bones, the different architecture that creates or composes of bone. And really, when we're trying to assess bone, we're looking for pathologies, we're looking for fractures, we're looking at dislocations. There is also no reason for us to do a X-ray series of the complete skeleton, and we can actually look at a regional approach to our scanning. So that means either doing scans specifically of the hand and wrist, or of the elbow, or the shoulder, or particular long bones. X-rays are readily available, they're relatively cost efficient and cheap, and when we're looking at the radiation dosage, there are a variety of things that we can do to actually limit or reduce the radiation exposure to the patient. It has excellent spatial resolution, and the field of view typically will capture what we're looking for in the case of fractures or dislocations or obvious pathologies or cysts or tumours. And then also there's familiar characterization of abnormalities. If we're thinking about effective radiation dosage, it's important for you to remember that the amount of radiation that the patient is exposed to is going to depend on what it is you're scanning, how big the field of interest or the region of interest actually is, and then obviously how many scans you're recommending too. So if we had to put this into perspective, usually we compare radiation exposure to the background radiation exposure that someone will receive in their everyday life. Whether this is radiation that is emitted from our mobile phones or technological devices, radiation that is emitted from aeroplanes, or just daily activities, our daily environment. If we put this into perspective, a single X-ray of the extremities, so elbow or the tibia and fibula, for example, is the equivalent to 3 hours of background radiation, which we can see is not a great deal. However, if we then increase and look at a spinal X-ray, for example, so that's going to be an X-ray of the vertebral column, we can see that this is then equivalent to 6 months of background radiation exposure. In contrast, if we then had to do a chest CT scan, this is then going to be equivalent to 2 years of background radiation. So as you can see, we usually start off with X-rays, and then if need be, we then step up to CT scans. You might be then thinking, well, what about the other tissues that comprise of the musculoskeletal system? We don't just have bones. So if we're then looking at the assessment of soft tissue, particularly in the case of ligaments or tendons, the go-to is usually going to be ultrasound. We won't cover ultrasound at this stage of your studies, but we will progress to ultrasound later on in year 2. So just keep in mind that X-ray is fantastic for the visualization of bone, particularly that cortical outline, the trabecular composition, and as well as the alignment and the articulation between bones, but ultimately any soft tissue, ligaments, tendons, if we're trying to assess joint spaces, which include synovial fluid, ultrasound is usually going to be the first imaging modality that you'd use in that case, and then step up to MRI if need be.